Okay, now let's get started. Is everyone clear on what I just went over? Or clear as you can be? If not, let me know. Okay, so let's start with the hip. And also, I'm having another session on Thursday, and I will cover the leg and the foot then. I kind of figured that you guys have been tied up with EPC and OPP over the weekend, the past few days. So I wanted to give you a chance to look at, especially the foot, before we cover it in tutoring. That way, if you have any questions, you have a little more time. Like I'll be here on Thursday too. Okay, so I kind of stuck with a lot of Dr. K's slides and just made like little notes and additions to them. So my advice for Dr. K, he is very clear and very straightforward in lecture, and he does not give you um, any information that's just fluff or that you don't need. So you really need to understand everything that he's presenting. But I don't know if you guys agree, but I think he is very like straightforward and clear. Okay, so I left this chart in here. He likes to ask questions using this chart. If you've noticed from his practice questions, he'll talk about like there's an injury to such and such nerve and what actions are affected. So I would definitely consider looking at this chart and trying to learn it this way because this is how he likes to test it. All right, moving on. Don't forget your sacrotuberous and sacrospinous ligaments. Those will be tagged on the practical. And I believe last year they tagged them in the donor. So make sure you're confident with identifying them in the donor, not just on the model. Okay, so let's start with the ligaments of the hip joint. So last year on the practical, what they did is they set out a hip model like this with the ligaments, and then they tagged a ligament. And not only they didn't just ask you, what is the name of this ligament. It was sort of a second order question, like here is this tagged ligament, and this ligament is going to prevent or limit what. So let's start with the pubofemoral ligament. What is that ligament going to prevent? Right. So pubofemoral is going to prevent hyperabduction. How about the iliofemoral, the giant one up here? Right. So iliofemoral is going to prevent hyperextension. So if you're standing upright, it's going to prevent basically your torso from falling backwards over the pelvis. And then I think also he mentioned that this prevents you from doing the front splits. So iliofemoral would be preventing front splits. Pubofemoral would be preventing side splits. And then your ischiofemoral ligament, what is that? Yeah, James Brown splits. Ischiofemoral ligament, what is that going to limit? Right, internal and external rotation. Okay, so if you can identify the three ligaments and then explain, what they prevent or ligament or what they prevent or limit, then you're going to be good for this slide. Okay. Next, this ligament, known as the ligament of the head of the femur, You'll also hear this called the ligamentum capitis femoris. So another one of those things where there's two names for the same thing. And so what he pointed out here was the fact that there is an acetabular branch of the obturator artery that is existing within this ligament. So someone explain why this is clinically significant. Right, he did use the MBA example. Okay, so if it's dislocated though, what happens to the blood supply to the head of the femur? Right, so if your patient dislocates their hip, this ligament can be ruptured, and then the head of the femur isn't receiving adequate blood supply. So then what happens? Right, necrosis. And this may or may not be important to know. Um, this is generally more significant in the younger population. So I guess it's just assumed that as an adult, you're going to have enough blood supply from other sources to perfuse the head of the femur. So I believe that when this is a bit of most concern is in a younger patient. Okay. Yeah, so they squeeze the hips to yeah, maybe not so much the ligaments, but just to make sure that there's no hip dysplasia. Okay, he mentioned a certain artery that serves as the primary blood supply to the hip joint. Which artery is that? Right, the medial circumflex artery. And in what type of hip fracture is this artery commonly ruptured? So if you want to be most specific, you would call it not intertrochanteric, intracapsular, right? So the medial circumflex artery is commonly ruptured in an intracapsular hip fracture. Okay. So he asked you guys to make sure that you could label this x-ray of the pelvis and femur. So let's just start with A up here. What is A? Yeah, so A is the ASIS, and then B is AIIS, and what does that stand for? Right, anterior inferior iliac spine. So anterior superior iliac spine and anterior inferior iliac spine. What is C? The head of the femur, right? What is D? Greater trochanter. How about E? The acetabulum or the vinegar cup. F. The neck of the femur, right? What about G? Lesser trochanter. H is the ischial tuberosity. And what about I? Right, it's the pubis, or I assumed he was going for the prominence on the pubis, though. What would you call that? Right, the pubic tubercle. And what attaches there? Inguinal ligament, right? And what is the other attachment for the inguinal ligament? ASIS. Good job. I will say from last year that Dr. K does like to use imaging on his exam. So make sure that all the images that he's shown you, that you're comfortable with them. And if you are, like, you should see something very similar on the exam itself. Then he also mentioned that you would have 2 images on your practical. Okay. Hip fractures. The only one he seemed to focus on was this one. So intracapsular hip fracture is associated with the rupture of what artery? Right, the medial circumflex artery. To be honest, I don't remember last year being asked to identify the different types of fractures. I think that's more of a second year thing, honestly. So I wouldn't get too worried about it. I would focus on just like the normal imaging. Okay, so here are the gluteal muscles. The biggest thing that I want to point out is so it's like a common mistake that people will make is that they think the gluteus maximus is innervated by the superior gluteal nerve just because it's the most superficial muscle, but it's actually innervated by the inferior gluteal nerve. So just make sure that you keep that straight, because I definitely remember being tested on the innervations of some of these gluteal muscles during the practical. And then this nerve right here, what is the name of this one? Still waiting for a correct answer. Not pudendal. Not obturator. Oh, somebody was very close. Not posterior femoral circumflex. Haley's been the closest. Yes, cutaneous. Posterior femoral cutaneous nerve. And what are its nerve roots? So nerve roots for posterior femoral cutaneous. That's your sacral plexus that you have to know, right? S1 to S3. Good job, Johnny. So he had a practice question involving these two facts down here, okay? So if your superior gluteal nerve is injured, you would have a deficit in what two motions? So if something happens to the superior gluteal nerve, what can you not do? Right? Right, so abduction, abduction, and medial rotation. And what about the inferior gluteal nerve? If you have an injury to the inferior gluteal nerve, what can you not do? Right, extension and lateral rotation. So definitely, highly recommend knowing that difference between superior and inferior gluteal nerve. That's a common one they like to ask about. Okay. So here we have your lateral rotators. And what did he refer to these three muscles as? He gave them a name. Does anyone remember? Right. A more, right, triceps, I see it, yeah, triceps coxae. Yeah, and then you can also think of this as the gemelli sandwich. So superior and inferior gemellus, making a sandwich of the obturator internus. Okay, and then what big nerve will you find exiting below the piriformis? Sciatic. Yeah, so if you have trouble orienting yourself back here, in the practical, I would start by finding the piriformis, and then you can kind of, um, you need to know this order, the order that the muscles appear in, and then also the obturator internus. That's going to look kind of like a shiny, silvery tendon. So that's another thing to kind of guide you here. And then the quadratus femoris is going to be a square-like muscle. So definitely get very comfortable with identifying these muscles on the donor because they will for sure tag them. Okay. I also noticed by watching the lecture that there was like a really wide like spread of answers to this question. So I just wanted to go over it and make sure that you guys understand it because this is what it's going to look like on the test. Like this is how he's going to test actions and innervations on the written exam. So what is the answer to this question? This is one of his questions from class. Right, so this is how this can be confusing. Okay, so physical examination reveals his right thigh extended, adducted, and laterally rotated. So he's laying there with his thigh extended, adducted, and laterally rotated. So all of these actions are unopposed, and that's why he's presenting this way. So if adduction and lateral rotation are unopposed, then what nerve is damaged? Right, those are all inferior gluteal nerve movements. So that means that his inferior gluteal nerve is still functioning. Yeah, so your correct answer is going to be F, the superior gluteal nerve. And what does the superior gluteal nerve do? abduction and medial rotation, right? So if he cannot abduct and medially rotate because his superior gluteal nerve is damaged, he's going to have unopposed adduction and lateral rotation by the inferior gluteal nerve. Does that make sense to everyone? Okay. So I would say this type of question is on par with like what you're going to see from him in the exam. Okay. So again, I just added this picture in case you're having trouble. I know we do like a lot of line drawings. In case you're having trouble like visualizing what the sacral plexus actually looks like in the body. And then I just wanted to clear up that the nerve to the piriformis is from S1 to S2, and then the posterior femoral cutaneous nerve, also known as posterior cutaneous nerve of the thigh, arises from S1 to S3. Okay. Again, with the sacral plexus, you definitely have to know this for your exam. Okay, so I'm going to go over this mnemonic for anyone who hasn't heard it yet. I highly suggest that you use it. I think it's extremely helpful. Okay, so during the exam, you're going to take out your sheet of paper and you're going to go 4-5-1, 5-1-2, 1-2-3, 2-3-4, and 3-4-5. Okay, and then you're going to start drawing lines. A line here, a line here, a line here, and so on. And this is telling you that L4 to S1 are your nerve roots for the superior gluteal nerve and the nerve to the quadratus femoris, which also gets the inferior gemellus. So if you think about how these are organized anatomically, like let me go back here. Okay, so you see how the inferior gemellus and the quadratus femoris are right next to each other? So it makes a lot of sense that the nerve to the quadratus femoris could help out the inferior gemellus and also innervate it. So if you can have this picture in your head, when you're looking at this, I think it makes more sense. Okay, so L5 to S2 is going to be inferior gluteal nerve, nerve to the obturator internus, and which also gets the superior gemellus. S1, 2, and 3 is posterior cutaneous nerve of the thigh. S2 through 4 is the pudendal nerve. And then L4 to S3, so you're going to draw a line all the way down and then under sciatic. And so that gives you the nerve roots for the sciatic nerve. So this right here is exactly what's on Dr. Dugsick's slide when she taught you the sacral plexus. So this is what I would know. So stick to this, and you will be good. And then the SIPs, of course, this is lining up over here. So I think this is really helpful. If you're still confused, here's the video explaining it. All right. So what did I want to say about this slide? Is there a compartment for the lateral rotators or no? No, they don't divide the gluteal muscles up into compartments. So like anterior, posterior, medial, that's only important in the thigh and the leg, or it's only like helpful in the thigh and the leg. There really isn't no way to divide them up in the gluteal region. But I think if you learn the sacral plexus, that helps you learn the gluteal muscles. Okay, so someone told me about sciatic nerve entrapment. Why is it important? Like what happens? Like how would the patient present? Right, so it can be impinged by the piriformis, pain down the leg. What part of the leg? Or instead of saying leg, what should you say? Thigh, right? So pain down the back of the thigh, numbness, tingling, yeah, all those things. So if you see a description like that, like a patient presentation like that, they're probably referring to the sciatic nerve entrapment, also known as piriformis syndrome. Did he say numbness in foot? Um, I don't think so. I do not recall him saying that. I think the common, yeah, no, it's okay. I think the most common presentation is like in the butt, pain in the buttocks and down the back of the thigh. Alrighty. So if you are going to perform an intramuscular gluteal injection, where do you do it? Right. The upper right or superolateral quadrant. I do remember there being an exam question about this last year, but I mean, that's literally the extent of it, you know. Where do you inject? Right up here. And why are we doing it up here? What are we trying to avoid? Right. Yeah, avoiding the sciatic and the other nerves in this area. The superior lateral or upper right quadrant is typically a safe area to aim for. All right, so Trendelenburg gait. This is the result of a deficit in what nerve? Superior gluteal nerve, and that's going to affect what muscles? Right, the medius and the minimus. What innervates, what innervates the gluteus maximus? Right, the inferior gluteal. So basically, you get what they call hip drop, and then the trunk is going to compensate by leaning to the ipsilateral side. So I would suggest if you just get on YouTube and type in Trendelenburg gait, you're going to get tons of videos, you know, so you can kind of, I think it's easier to understand this when you can see somebody who's walking like this. So I just recommend doing that. You know, just take a minute and type in Trendelenburg gait, and watch a few videos. Okay, you try to walk like that. Right. So the pelvis is going to drop to the contralateral side. However, the trunk, so the torso or upper body, is going to compensate by leaning to the ipsilateral side. Is that clear? Yeah. Okay. Cruciate anastomosis. So this really just comes down to memorization, I think. I'm not sure if there's really a great way. yeah, to learn this other than to just memorize it. So your cruciate anastomosis is made up of your inferior gluteal artery, the medial and lateral circumflex arteries, and then the deep artery of the thigh. Specifically, what branch of the deep artery? Yeah, so the deep artery of the thigh is a branch of the femoral, but the artery contributing to the cruciate anastomosis, it is a branch of the deep artery of the thigh, and it is known as, so profunda brachii is the same thing as the deep, um, or I'm sorry, I think it's profunda femoris. So profunda means deep. That's referring to the same thing as the deep artery of the thigh. But there's a branch off the deep artery of the thigh. No, okay, so it's the first perforating branch of the deep artery of the thigh. So specifically, that is the branch that is contributing to the cruciate anastomosis. And you'll see that, I think that is how it's described in first aid and a lot of other resources. It's called the first perforating branch of the deep artery of the thigh. Okay, and then you also want to know that the cruciate anastomosis is forming a connection between the internal iliac and the femoral artery. Okay, so know the four arteries that form the cruciate anastomosis. Okay, and then the venous drainage is pretty straightforward. It just follows the arteries. I would say the only one that's like really special that they're probably probably I mean definitely going to test you on is this one right here. So the great saphenous vein is entering what opening? What is this opening called? The saphenous opening to drain into what? The femoral vein, correct. So I think last year they tagged the great saphenous, so make sure you know that one. All right, let's do the thigh. Okay, so the deep fascia of the thigh is known as the fascia lata, and then the deep fascia of the leg is known as the crural fascia. So that's really the most important thing to know here. And what is this muscle right here? This one here. Give me the full name. It's okay if the spelling is iffy. Yeah, tensor fascia lata. So definitely, don't forget about this muscle. You can find it, uh, by locating the IT band, and then it's going to be just superior to that. Oh, that's unfortunate. Okay, so what is compartment syndrome? What is compartment syndrome? Right, so you have increased pressure in the compartment, and yeah, you're right, the fascia doesn't expand. So as a result, what is happening to the nerves and the blood supply within the compartment? Right, they're being compressed, and then what's happening to the, yeah. a lot of compression. So yeah, death of tissue. Yeah, you guys are all correct. Um, so this is, considered an emergency because, basically, you get necrosis just because everything in the within the compartment isn't being adequately perfused. So they perform a procedure called what? Right, a fasciotomy. And one thing he didn't say, which is like how you'll see it anytime you do like a board practice question and how they'll describe it next year, is that compartment syndrome is associated with pain out of proportion um, to the extent of the injury. So if the pain is far beyond what would be expected for that patient's injury, then that may be a clue that they may have compartment syndrome. And there's what's called the 5 Ps of limb ischemia that's related to compartment syndrome. So that's pain, pallor, paresthesia, pulselessness, and paralysis. So anytime, you hear those things in a question stem and you hear them describe it as, pain beyond what is expected, then that's a hint that they're talking about compartment syndrome. Can this be palpated? What do you mean by that? Like the fact that there's increased pressure? Oh, honestly, I don't know. Kind of like what they taught us is it's diagnosed based on, physical signs and symptoms, and then that person goes to surgery. But to be totally honest, I'm not sure what you would feel on. I mean, you wouldn't feel a pulse. That would be a big sign. So yeah, if you couldn't palpate a femoral pulse, then sure. Okay, we'll keep going here. Okay, so thigh, a good way to think about the nerves and the actions. Definitely take a look at this. Okay. Yeah, I think you're right, Sarah. But you would be able to palpate the fact that there isn't a pulse. And then you would see the pallor, like the whiteness of the leg due to the ischemia. So, I mean, those things might be a clue. Okay, so we went over the pectineus. Oh, no, that's no problem. Yeah, I have the same problem when I'm at home. Zoom always kicks me off. Okay, so we kind of went over the pectineus. So for exam purposes, the pectineus is innervated by the obturator nerve. Um, However, its primary function is going to be hip flexion. So, but just keep in mind, like I said, you might see some sources where it groups the pectineus as a medial compartment muscle. And, this is unique because it's innervated by the femoral nerve and, according to Dr. K, the obturator nerve. He told you femoral? Okay, yeah. I mean, I suggest that you guys bring this up to him and ask him, for clarification. Because when I emailed him, he said that he would go with what was discussed in class. Yeah, so I think that he may have just misspoken that day. Um, so yeah, your textbook and everything is going to tell you that the pectineus is innervated by the femoral nerve. Sorry for that confusion. I wish that wasn't the case. Okay, and then what else did I want to say with this slide? Okay, so which muscle here is, why is it an exception again? Okay, so the pectineus is often grouped as a medial compartment muscle. It's the most anterior muscle in the medial compartment. However, it is innervated primarily by the femoral nerve, and it is responsible for hip flexion. However, in some patients, you're going to get like an accessory branch of the obturator nerve that will also innervate the pectineus. Okay, so which muscle here is the most powerful hip flexor? Right, the iliopsoas, and it's formed by what two muscles in the posterior wall of the abdomen? That are passing into the thigh to form the iliopsoas. Right, the iliacus and the psoas major. So iliacus and psoas major are going to form the iliopsoas. Not to my knowledge. He didn't mention that the minor contributed to the iliopsoas. Okay. What muscle in the anterior compartment is going to cross both the hip and the knee? Right, the sartorius. And what are the actions of the sartorius? What does the tailor do? Right, so hip flexion is correct. What else does it do besides hip flexion? Yeah, it's a weak abductor and lateral rotator. But what about at the knee? What does it do at the knee? Yeah, it does. Does that not extend the knee at all? So, what extends the knee in the anterior compartment? Right, the quads. And okay, so what I'm getting at here is that the sartorius is going to flex the knee and the hip, right? So sartorius flexes the hip and the knee, and then the quads are going to extend the knee. Does that make sense? So, leg on the other leg when you're seated. Yes, Dr. Doolittle, yes. Okay, so when we say quadriceps femoris, what four muscles are we referring to? Right, vastus lateralis, medialis, intermedius, and the rectus femoris. And I know something that can be confusing in lab is the fact that this vastus intermedius is located underneath the rectus femoris. So you would have to either reflect the rectus or kind of move it to the side to see the vastus intermedius. So just kind of keep that in mind. Oh, you're fine. Okay. So let's do the femoral triangle real quick here. Okay, so you need to know all of the details of the femoral triangle. Okay, so the roof, the floor, the borders, the contents, everything. So the roof of the femoral triangle is formed by the fascia lata, and then the floor is formed laterally by the iliopsoas, and then medially by the pectineus. And then our borders include the inguinal ligament, so ASIS to pubic tubercle, laterally the sartorius, and then medially the adductor longus, and then the mnemonic that everyone uses from lateral to medial is navel, so femoral nerve, artery, vein, an empty space, and then some deep inguinal lymph nodes. So if you see little things that look like kidney beans, those are going to be lymph nodes, but like to my knowledge, like they're not going to tag a lymph node on exam on a practical, so don't worry about that. Okay. They didn't look like beans. Oh, what did they look like? How would you describe them? Oh, magic beans. Are you Johnny's twin, Professor Suzuki? Okay, so something that I found helpful, somebody told me this. Okay, so if you know navel, but you don't know if it's medial to lateral or lateral to medial, it's not going to be very helpful to you. So remember that you go from lateral to medial to find your navel. So of course, navel is another word for, like belly button. So you have to come from lateral to medial to find that belly button or find that navel. So that should help you remember the order of this mnemonic here. Okay. So some clinical correlates. The first one is myalgia paresthetica. So this is referring to that lateral femoral cutaneous nerve. And so the patient's going to present with paresthesia of the lateral thigh. Right. Also known as hipster syndrome. So if you, in the lecture exam, are given a presentation about like either an obese patient or like a carpenter wearing a heavy tool belt, or a patient who like wears a tight belt to work, and they have numbness or tingling in the lateral thigh, you want to think lateral femoral cutaneous nerve. Yeah, yeah, there you go. Okay, so another important one is the femoral hernia. So if you have a femoral hernia, loops of the intestine are going to herniate into the empty or potential space here in the femoral triangle. So yeah, that's really the extent of what you need to know at this point. Oh, and then he talked about how, if you find the AIS and the pubic tubercle, about halfway in between, you'll find the femoral artery. And, if you compress the inguinal ligament, it's going to help you, compress this artery and potentially stop any bleeding downstream. So if you ever, find yourself in the battlefield or, shooting at a bar, I suppose this could be helpful. Okay, I'm going to get there about the femoral sheath. So give me just a minute. Is that direct hernia medial to epigastric artery? Yes, Professor Ben. All right, so here is the femoral sheath slide. Okay, so what are the contents of the femoral sheath? What is contained within the femoral sheath? Right, the femoral artery and the femoral vein. That's correct. And then the nerve is not within the femoral sheath. Okay, so this is a definite test question. I don't remember like how exactly they asked it. I mean, I'm sure they had some fancy way of asking that. But if you know the contents of the femoral sheath and the fact that the femoral nerve is not included in the femoral sheath, then you will be good to go. Okay, so the clinical significance of the femoral canal, we kind of talked about that with the femoral hernia. So the fact that this canal is here, it's giving kind of an empty space or a passageway for contents of the abdomen to herniate down and out through the saphenous opening. Why is it important that the nerve is not in its own sheath? I will have to look that up. Like, I can't think of any like clinical significance we learned about that. I suppose the only thing I can think of is that if the nerve was in a sheath, it needs to, yeah, that's what I was getting ready to say. It needs to innervate the muscles. So if it was wrapped up in a sheath, it can splay out and provide all these branches to the muscles of the anterior compartment. Yeah, at this point, knowing the contents of the sheath and what's not in the sheath, that needs, that needs to be your focus right now. I know it seems trivial, but they're going to ask you about it. So just know it. That's my point. Okay, so a common question people have is about this saphenous nerve. So first of all, what is the saphenous nerve a branch of? Where is the saphenous nerve? Right. The saphenous nerve is a branch of the femoral nerve. And what is its job? What does the saphenous nerve do? It's cutaneous. To where? What region? Right, so kind of the medial side of the leg. Okay, so where people get confused is you'll read different things about the contents of the adductor canal and hiatus. Okay, so what they want you to know for MGA is that passing through the adductor hiatus are two structures. What are those two structures? Femoral artery and vein, correct. Okay, so if you're asked for the contents of the adductor hiatus, you're going to say femoral artery and vein. The reason people get confused is because the saphenous nerve is also going to travel with the femoral artery and vein through the adductor canal. So the adductor canal is different than the adductor hiatus. The adductor canal is this right here. So this kind of like fascial sheath covering the artery, vein, and saphenous nerve, that's the canal. The saphenous nerve is going to pop out of the canal before the femoral artery and vein exit the adductor hiatus. Does that make sense to everyone? Okay, yeah, so right here is the canal, and then if we go to this slide, the opening here is the hiatus. The problem is, this is a 2D picture, so this really isn't giving you a good idea of what the canal actually looks like. So you have a canal that leads to an opening, and that's the hiatus. Okay? Right. I think it's just like a small branch. Yeah. Okay. Let me do this one more time. Okay. First of all, this artery popping off here. This is just like a small muscular branch, I think. I don't know if it has a name. We did not learn it. Okay, so this right here is not the femoral artery. It's just a small branch coming off of it. It's not significant for your purposes to know for MGA. Okay, let me do this one more time, okay? All right, so the femoral artery and vein are going to run with the saphenous nerve, which is a branch of the femoral nerve. Those three structures are going to pass through the adductor canal. So the canal is covered by like this fascial sheath, and then they're going to exit in the popliteal fossa, and they're going to exit this adductor hiatus to become the popliteal artery and vein. Okay, so you have three structures traveling in the canal. The saphenous nerve is going to exit early. So see how it's popping out through that fascial covering? So it's exiting the canal. That way the only two structures that exit the hiatus are going to be the femoral artery and the femoral vein. Is everyone okay with that? So if they ask you for the contents of the adductor hiatus, you're going to say femoral artery and femoral vein. So if you start going to outside resources and get confused, just don't do that. Make sure you stick with what Dr. K said in class. Okay. So femoral artery and vein exits the adductor hiatus. What else do we need to know about the positioning about the saphenous nerve before the canal? Yeah, so after it exits the adductor hiatus, it's going to enter the popliteal region to become the popliteal artery and vein. So Haley, to answer your question, the positioning of the saphenous nerve, you just need to know that it's branching from the femoral nerve, and then it's entering the adductor canal, but it exits before it reaches the hiatus to supply cutaneous innervation to the medial aspect of the leg. Because if it traveled backwards to the popliteal fossa, then it would end up in the back of the leg, and it wants to be out here on the medial side. Is that what you're asking? Does that make sense? Mostly so to my knowledge, it's mostly the medial aspect of the leg, since the adductor canal is all the way down here. It might be getting a little bit of the thigh, but don't stress about those minor details. If you can identify the saphenous nerve, like that's good enough. Okay. Okay, so medial compartment muscles. Yeah, the great saphenous vein runs with the saphenous nerve. Yes. Okay, so medial compartment muscles, know them, know that they're supplied by the obturator nerve, and then know that the pectineus is commonly considered part of the medial compartment. So it's the most anterior muscle in the medial compartment, but it's innervated by the femoral nerve. But of course, I would talk to Dr. K about this because I think who said Haley said, was it Haley that said he told her it was innervated by femoral? Somebody said that. Okay, but talk to him about it. Okay, yeah, bug him about it, but just don't tell him that I told you to bug him about it. Please. Okay. Okay, so how would you locate the obturator nerve? He kind of went over this in class. How, okay, let me rephrase that. Obturator foramen, but how would you locate it in the thigh? So he talked about finding the gap. Right, so yeah. So if you're looking for the obturator nerve in lab, he referred to the gap as the gracilis, the adductor longus, and the pectineus. So between the pectineus and the adductor longus, you should see the obturator nerve. But yeah, Professor Suzuki, yeah, I believe ideally, right, pectineus. Um, Ideally, you're right. I think it is lying like on top of the adductor brevis. Yeah, it shows it right here. Oh, good. Okay, so posterior compartment of the thigh. Um, let's see, a few important things. Okay, have you guys heard of the boys to men mnemonic? Yeah, in boot camp. Okay, so is anybody here that wasn't in boot camp? Yeah, okay, so boys to men, this is a mnemonic to remember the muscles of the posterior compartment of the thigh. So boys is going to be biceps femoris, 2 is semitendinosus, and then M is semimembranosus. So boys to men. So from lateral to medial. And I think in boot camp, somebody told me that a group of people came up, they were having trouble like remembering if the mnemonic was like which direction it ran in. So somebody told me that they decided that they could remember that boys to men was lateral to medial because if you're, was it Johnny's group? Okay. So, Johnny, you can, yeah, correct me if I get this wrong. Okay, so if you're a boy, you can touch like the outside of a girl's leg, with her permission, of course. But if you're a man and, married and you have consent and all of that sort of thing, obviously you can start moving from lateral to medial, with permission and all that sort of thing. So, yeah, sorry if that's offensive to anybody, but I think it's like extremely helpful to remember this. Yeah, you'll never forget it. Um, so, yeah, I mean, I don't like to offend people, but I think it's helpful. So, yeah, I can repeat it again. Okay, so boys to men is going to help you remember the posterior compartment muscles. So boys refers to the biceps femoris, 2 refers to semitendinosus, and then men, the most medial muscle is going to be semimembranosus. So for that mnemonic to be helpful, you have to remember is boys to men medial to lateral or lateral to medial. So boys are, only touching, the outside of the thigh, And then, of course, men, going a little more medially. All right, so hopefully that's helpful. Okay, so to make sure this is clear, what is this and what are the two structures that it's conveying? Anybody? The adductor hiatus. And what two structures are passing or are exiting the adductor hiatus? Right, the popliteal artery and vein. And prior to exiting the hiatus, what were they known as? Femoral artery and vein, right. Okay. So, did he skip this slide in class? Or did, something happen with Mediasite? Did he go over this? Yeah, okay. So if he skipped it, I'm not sure why, but this is actually really important, okay? So the pes anserinus, it's referring to the attachment of these three muscles. So semitendinosus, uh, the gracilis, and the sartorius. Oh, and I just thought of a mnemonic. Yeah, Sergeant Goose, or yeah, Sergeant uh, Foss. Yeah, okay. So somebody explain that mnemonic. Type it into the chat box. I think this was a boot camp thing. So for those people that weren't in boot camp, go ahead and explain that to them. Right. Yeah. Both Haley and Professor Ben are correct. Okay, so the pes anserinus has a representative from each compartment, and each of these muscles are receiving a different innervation. Okay, so like she said, Sergeant Foss. That's how we remember this. All right. Um, okay, so cruciate anastomosis again. Okay, so what are the four arteries contributing to the cruciate anastomosis? You definitely need to remember these. Right, okay. So Haley's got a complete answer there. So inferior gluteal artery, medial and lateral circumflex femoral arteries, and then the deep artery of the thigh, specifically the first perforating branch. Okay, yeah. So somebody, why is this important? And that's getting at my question up here. The cruciate anastomosis provides a connection between what two arteries in case there's a blockage. Right, so what two arteries is it providing a connection for? Right, the internal iliac and the femoral artery. Yeah. Alrighty. So make sure you know that the four arteries contributing to this anastomosis, and then what two arteries it's providing connection for. Okay. The great saphenous vein. So it's going to pass through what opening to drain into what vein? Drains into the femoral vein, correct? And it passes through what opening to do that? Right, through the saphenous opening. Good job. Okay, and like I said, last year they tagged the great saphenous vein on the practical. So make sure you know that one. Okay, so one more in the knee. Okay, so you definitely want to know the difference between genu varum and genu valgum. So genu valgum, the way that we remember this is, so GUM is gum, and gum is going to make your knees stick together. Okay, so if someone has genu valgum, this means that they are knock-kneed. If someone has genu varum, they're bow-legged. So gum makes your knees stick together, and rum makes your knees, fall apart. Yeah. Yes, homie. Okay. So, just know that much and you'll be good for this slide. Okay, let's label this radiograph real quickly. Okay, so what is A? Patella, what is B? Right, the fibular head. And what is C? So be careful with C. Not medial head. Yeah, somebody fell into the trap here. Okay, so is this medial or lateral epicondyle of the femur? Medial. Why? How do you know that? Right? Because the fibula is lateral. Yeah, so don't let that one trick you. That'd be a really good way to trick people in the practical. Okay, so if this is medial, what is this? Right, lateral, femoral condyle. What is this? What is E here? Right, the tibial eminence formed by the tibial tubercles. And what is F? Uh, right, so it's the tibia, tibial tuberosity. Yes, that's what I was getting at. So bony prominence here is the tibial tuberosity. Okay, you need to know all of the ligaments that he has listed here. Okay, so anterior cruciate ligament, posterior cruciate ligament, the lateral collateral ligament, the medial collateral, and then the medial and lateral menisci. Let's go on to this slide. Okay, so if you're doing an anterior drawer test, which ligament are you testing? Right, the ACL. And what is the ACL's job? What is it preventing? Yeah, so it's preventing, yeah, anterior tibial translation. Okay, and then how about the PCL? What is it preventing? Right, the opposite, posterior tibial translation. So if you have a positive anterior drawer sign or anterior drawer test, this means that the tibia is translating um, further anteriorly than it should be, and that's indicative of an ACL tear. They will always tell if it's the right or left leg. Do you mean they'll tell you if it's a right or a left leg? Like if they give you an image or um, probably not, because you should be able to identify medial versus lateral based on the fibula. So they should show you the fibula, and then if you see a ligament running from the lateral femoral condyle to the medial tibial eminence, then you know that's ACL. And then a ligament running from the medial femoral condyle to the lateral eminence, that's PCL. Does that help at all? So, yeah, if you get confused, I would recommend knowing the attachments of the ACL and PCL. Okay. Oh, right. Yeah, I agree. I agree with what you're saying. I don't think that he would give you an image that's that confusing. I think didn't that image show that the ACL was ruptured or something? You won't be asked to identify pathology like that. I mean, I don't think so. So yeah, ask him, but I wouldn't get too worried about it. Yeah, I don't remember having to identify the knee ligaments on MRI last year. Like, what I remember them doing is them tagging it in the donor. So they could tag these ligaments in the donor. So you should have like one donor um, in your lab that's had like a complete knee dissection. Is that true? Yes, no? Yeah, so make sure you look at that. That's probably how you're going to see it on the exam. Okay, so if you're performing a valgus stress test, you're testing the integrity of what ligament? Right, the medial collateral ligament. Yeah, and yeah, this is the reason I did this, because it took me forever to get this straight, because it's to me it's kind of counterintuitive. Like if you're pressing on the outside of the knee, you would think that you're testing LCL, but you have to think about the direction of the force. So you're actually testing the integrity of the MCL, or medial collateral ligament. So if you're doing a varus stress test, then you're pushing outward and you're testing the integrity of the lateral collateral ligament. Q angle during the valgus test. um, honestly, increase. I'm honestly not sure. Even in second year, they really didn't make a big deal about the Q angle. So to answer your question, I don't know, but I can look that up at the end though. What you really need to know is just which ligament you're testing with each of these exams, because even when you do this in EPC, a positive valgus stress test, um, that happens when you notice that there's laxity in the MCL. So, we don't really measure angles or worry about that. It's more based on feeling when you perform this exam. Okay. So O'Donoghue's unhappy triad. So really the only thing you need to know here is that the unhappy triad is made up of the ACL, the MCL, and the medial meniscus. He had a unholy triad, but as far as I know, like if you look at any sources, it's always going to call it the unhappy triad. And in fact, somebody said unholy triad to Dr. Chestnut this year, and he laughed at them. So I would stick with unhappy triad. I think this is typically how you're going to hear it, or what you're going to hear it called. Okay, so ACL, MCL, and medial meniscus. And then one more thing. So what is different about the MCL and medial meniscus versus LCL and lateral meniscus? Yeah, which ones are attached or not attached? Yeah. So medial meniscus and MCL, the fibers blend together. That's why when you have this unhappy triad, that both of these tend to be injured. Okay. Oh, I did include this picture. Is this the picture you guys were referring to? Yeah. I felt the same way that you did. I could not really tell either. So I know, like in his notes, he had number 7 labeled as ACL and then 6 is PCL. I mean, I would love to say don't worry about it, but I would ask him. Like, I really don't remember, being asked to do this on the exam last year. But you can ask him about it for sure. Okay. However, he will be asked to do this. Okay, so again, the popliteal fossa and the femoral triangle, you need to know everything about both of these. Okay, so the roof of the popliteal fossa is the popliteal fascia, the floor is the popliteus, and then the popliteal surface of the femur. Popliteus is most important here. Your borders are the biceps femoris laterally, the semimembranosus medially. So I noticed this year that he just said the semis. Last year he taught it that it was the semimembranosus. I think it's so. I think kind of the consensus is that it's mostly the semimembranosus with some contribution from the semitendinosus. So, if you see conflicting stuff out there, I think for MGA it's good enough just to know that it's the semis that make up the superior medial border. Okay, inferior medially is the medial head of the gastrocnemius, and then inferior laterally is the lateral head of the gastrocnemius. There is not any mnemonic that I know of, but if you remember your boys to men, then I think that makes it easier to remember that your biceps femoris is going to be laterally. Because all you really need to know here is that it's the semitendinosus and membranosus contributing to the medial border. So just remember boys to men, and that should help with this. Okay, let's see. So your contents are the popliteal artery and vein, and then your tibial nerve, which is a branch of what nerve? the sciatic, right? And then the common fibular nerve, which is right here. And then both the common fibular and the tibial nerve are going to give off these smaller contributions to form the sural nerve, which provides cutaneous innervation in the posterior part of the leg. Okay, and then what is this vein right here? Right, the small saphenous. So small saphenous vein, and then the sural nerve is going to be running with the small saphenous. So that's important to keep in mind, to remember. Alrighty. Oh, yeah, and then, of course, some popliteal nodes. All right, here's that labeled again from his slides. I just wanted to point out, tibial, common fibular, and then providing contributions to the sural nerves in the posterior leg. Was that last picture the right leg? Okay, so you tell me, or somebody, yeah. So why is this the right leg? Somebody? Right, the Boys to Men gives it away. Yeah, so this is the medial part of the thigh. So that tells you this is the right leg. Okay. All right, so genicular anastomosis. I want to say that they tagged one of the arteries of this anastomosis on the practical. But if you just think about, thought he had it backward. Yeah, I think I was watching the video from this year, and he started to draw it backwards and switched it around or something like that. Okay, so genicular anastomosis. So this anastomosis is providing a connection between what two larger vessels? Do you guys remember? Right, femoral and tibial arteries. So make sure you know that. So you want to know your genicular anastomosis and then your cruciate anastomosis. Okay. So, yeah, I'm glad we did not attempt leg and foot tonight. All right, so that is all that I have for you guys. There was a question about the Q angle. Let me see if I can find something about that. Yes, Professor Suzuki, you are correct. Okay, so I'm having trouble answering the question about the Q angle just right off the bat here, so I will look into that and have an answer for you guys for next time, okay? But honestly, we were not asked anything about Q angles last year in the exam. Just know the difference between genu valgum versus genu varum and what that looks like in the patient, and you should be just fine, okay? But I will definitely look into your question. Good. I'm glad that you like it. Yeah, I try to do that to make sure you guys are getting the main points of each slide. I will keep doing that then. Yeah, have a good night, you guys. Yep. I'll be here on Thursday to do the leg and the foot. Can you teach FMHC? No, sorry. Look at the study guides from last year, though. Ashley, Hamani, like all of hers were very good. I do have some good study guides and practice questions for the third FMHC exam. So if you send me a message, like I'd be happy to pass those along to you guys. All right, well, I'm gonna get off here.